but the most updated one I will upload
Okay, thanks.
after this. Yep. So spine differential diagnosis. Okay, so I want to start off first talking about the just general idea, and this theme will kind of come up as just throughout the different diagnoses talks, but just reminding you guys that musculoskeletal pain is pain that can be reproduced, so it's mechanical. Nerve pain or neuromuscular pain that radiates, and you're going to have some sort of nerve symptoms usually. And then non-musculoskeletal pain, for example, cancer, is pain that you can't reproduce. And usually people will give it different descriptors. So it'll be a gnawing pain, intense pain, night pain, and you'll have some of these red flag symptoms associated with it. So we're going to kind of go top down. So I want to start in the cervical spine and then work our way down, thoracic and lumbar, and see if we can get to all those different body areas. So there is a lot in cervical, so bear with me. In cervical, we do want to rule out some of these red flag findings or things that may need further attention outside of physical therapy or non-musculoskeletal related diagnoses. So first couple things we're thinking about in cervical spine of ruling out, especially if there's trauma involved, are we want to rule out fracture and we want to rule out upper cervical instability, because those two things are dangerous. They can have significant side effects. They can be fatal if not treated or if not appropriately dealt with, because you can have spinal cord compromise, is the main thing. So you have risk for paralysis or further serious injury. So in order to rule out fracture, if we do suspect fracture, we're going to go through the Canadian C-spine rules. So I'm going to leave those on there for your reference. I assume you guys are familiar and have studied those. So I don't want to read things verbatim for you, but I do want to go through some of this decision making, and then obviously these notes are kind of a reference for you. The other thing we want to do is we want to rule out upper cervical instability. So a few things that are going to predispose certain individuals to instability of the OA joints, specifically glenoaxial joint or occipital, CO, C1, occiput on atlas. So rheumatoid arthritis, RA, Down syndrome, Ehlers-Danlos, lump in the throat, that's sometimes described as a symptom of upper cervical instability, history of trauma, and then your neuro symptoms are going to predispose or going to clue you in that you may have this going on, and you want to screen, you want to ask these questions if you suspect it. You're also going to do your ligament testing. That's going to be important to rule out instability. As we talk about neck pain and different causes of neck pain that are musculoskeletal, we want to think about one of the proposed classification systems in the literature, which is a treatment-based classification system for neck pain. So we'll find in the lumbar spine that there's a similar treatment-based classification. And what this does is basically says, if we can group a set of impairments with this particular individual, we know this person's coming in with neck pain, but there are these specific impairments that may lead them to respond more positively to a certain set of selected treatments. So we're going to categorize them, not necessarily on what structure we think is going on. We can classify according to pathoanatomical model, but there is also this alternative model where we can classify based on what treatment we think they're going to respond best to. And so that's what this schema is set up. That's the aim of the schema. So in neck pain, we have 4 different treatment-based classifications, and they are neck pain with radiculopathy or radicular symptoms, so some sort of arm symptom, neck pain with headache, neck pain with hypomobility at a segment, usually at a segment, single segment, or single facet joint, neck pain with movement coordination impairments. So this can include whiplash-associated disorder, and other associated disorders. It doesn't have to be whiplash, but whiplash will be classified in this category. So these 4 disorders, as we kind of go down the list, cervical radiculopathy, usually to rule in cervical radiculopathy, we'll use Wayner's cluster of clinical tests, and his test cluster has 4 different tests. There's a little mnemonic written below that I tend to use to remember these tests, but basically so here's my mnemonic is shake your head no, push them, pull them, stretch them. So in other words, we are looking for an active range of motion. And if 3 out of 4 of these tests are positive, or 4 out of 4 of these tests are positive, you see the sensitivity below. It's a really high likelihood that they have radiculopathy, cervical radiculopathy. So we're looking for active range of motion, less than 60 is positive on that. Reproduction of symptoms with a Sperling's A, so side bend and compression. And the compression forces, so 7 kilograms on that. A supine distraction, so trying to relieve some of the radiculopathy or relieve some of the compression. And then a positive median nerve upper limb tension test. So if those are positive, it's a high likelihood of cervical radiculopathy. The other things that patients could report is that they get some relief with hand over the head. And that tends to be because they're reducing some of that traction force on the brachial plexus. And so they have some relief, or on those nerve roots, on those cervical nerve roots that are maybe compressed or causing some of their symptoms. They could have reproduction of symptoms with CPAs or cervical muscle palpation into their upper extremity. So radicular pain when you're pushing or pulling or moving something in their neck, they're going to have upper extremity symptoms. So that's characteristic of radiculopathy. Our second treatment-based class is neck pain with headache. This, on the outset, kind of sounds pretty obvious. So they're going to report some sort of headache, but the headache needs to have descriptors and have etiology that is cervical in origin. So it can't necessarily just be any headache. So migraine headache and neck pain might be 2 different things, but we really want to link the headache with the neck pain. So in other words, headache needs to be reproducible with some sort of, again, muscle palpation or your CPAs on the cervical spinal facets, UPAs at the cervical spinal facets. Usually the headache is described as unilateral in origin. It can be bilateral, and usually it's either a temporal headache or an occipital headache in which the suboccipital muscles are likely involved, or the upper cervical joint. So OA and AA joint can sometimes be involved in this lower headache. Temporal headache is oftentimes myogenic, so muscle related, muscle tension related, and that's either referral from, it could be scalenes, it could be SCM, it could be upper trap, levator scap. Those are common muscles that we tend to see refer in headache patterns or tension type cervicogenic headaches. These individuals could have reduced range of motion as well. Okay, so our third category is neck pain with hypomobility. Again, at the outset, don't make this harder than it is. So there's some sort of loss of motion. Usually there's loss of active range, passive range, and most characteristically is that we're going to see hypomobility as we test joint accessory motion or we test our PAVMs. So CPAs, UPAs are going to be hypomobile. They could also be tender, painful, and reproduce the patient's pain. These individuals tend to be younger with an acute onset. So these are the individuals who kind of woke up with a stiff neck or have a crick in their neck, have trouble with moving. Usually it's one unidirectional. So turning left is harder than turning right. Side bending, things like that. Extension would be a common limitation if we're thinking of facet dysfunction or hypomobility. These individuals aren't going to have upper extremity symptoms, not radicular, and that is majority for that category. Final category is going to be neck pain with movement coordination impairments. So again, this category includes our whiplash disorders. These individuals are going to demonstrate poor coordination, poor motor control of neck movement. They may have an inability to chin tuck or really struggle with that motion. They likely will have some reduced range of motion, either bilateral or unilateral. However, their greater problem or their greater dysfunction is a muscular dysfunction. And so oftentimes these individuals will have pathological or abnormal activation or strength of deep cervical neck flexors. So that's kind of going to be the hallmark of this category. You're going to test strength and endurance of those with the deep neck flexor endurance test and the craniocervical flexion test. So craniocervical flexion test is you're going to craniocervical flexion. I think I had these mixed up. I'll double check that before I post it. But I get those confused sometimes with the blood pressure cuff. That is the craniocervical flexion test, I believe. And then the deep neck flexor endurance test is where you're having them chin tuck and supine and lift. And the amount of time that they are able to lift and hold is going to be their score. So norms we know on that test are going to be right around 30 seconds for a normal individual. For somebody who has neck pain with movement coordination impairment, they're likely going to be much lower. So maybe 5-10 seconds they're able to hold that chin tuck, either because of pain or because of a weakness, really struggling with attaining that position and maintaining it with those deep neck flexors. These individuals could describe some fatigue, head feels heavy, sustained postures oftentimes are hard for them. So standing, sitting, holding their neck in one place, lying down usually relieves symptoms because they have some relief of that endurance demand on the neck. Okay, so those are our main treatment-based classifications for the neck. Again, like I said, we can classify neck pain based on pathoanatomical dysfunction, but really what we've gone to more often is this treatment-based classification, because just like in the lumbar spine, we know that the pathoanatomy doesn't necessarily correlate with the signs and symptoms, doesn't necessarily correlate with our clinical findings. And so we want to treat more comprehensively. And we know that there are a high proportion of individuals who, when imaged, either X-ray, MRI, will demonstrate some sort of pathological finding, but might not necessarily have pain or dysfunction. And so, not that we can't, and it could have made the list. I could have listed facet dysfunction, disc, things like that, stenosis for this cervical region. But I just wanted to highlight the treatment-based classes. And so we will go through that a little bit in lumbar. We're kind of looking at both the treatment classes and a little bit of patho-anatomical type differential diagnoses. I think what you'll find as described are going to be more often these treatment-based classes. Okay, so moving into the thoracic spine. If we remember, thoracic spine, because we have rib attachments, is going to be not as mobile as our cervical spine. Cervical spine is really notable because of its ability to attain mobility. Thoracic is going to be a little bit more stable, a little bit stiffer. A lot of what we're going to see in the thoracic spine are either facet joint dysfunction or hypomobility, or some sort of rib or costovertebral issue. So costovertebral joints and rib dysfunction is going to be an important one to differentiate from facet dysfunction, because they are so close regionally within the thoracic spine. So, excuse me, some things that we can do to differentiate between a facet dysfunction and a rib dysfunction are pain patterns and our findings on our objective exam. So localizing the patient's pain to a certain area. Again, palpation, we don't want to hang our hat on palpation. Palpation is just one of many clinical findings, but if we are having pain and tenderness with palpating at the facet joint, that's going to more likely indicate facet. If we have pain palpating the rib, that's going to be more likely a costovertebral issue. So it could be palpation at the rib, it could be palpation at that specific joint, or it could be our joint play assessment on the rib. So a PA spring at the rib could cause or reproduce a patient's pain. If that is the case, then we're thinking more of a costovertebral issue versus a facet issue. Facet dysfunction is going to be characterized by more of a sharp pain. Usually it's going to be some sort of acute onset, but not necessarily a traumatic mechanism. So it could be, again, somebody who woke up with a stiff back, or they noticed they sat in a position that was uncomfortable, and then after that, they've been having mid-back pain or upper back pain since then. Periscapular pain is oftentimes associated with these individuals, so you can have some referral from facet dysfunction into that periscapular area, kind of inside the shoulder blade region between the spinous process and the medial border of the scapula. It's not uncommon. However, that pattern is more indicative of facet versus a rib dysfunction. We tend to get radiating and referral around the rib distribution. So we tend to get more of a shooting radicular pain around the rib itself. So coming all the way around the rib cage, and that kind of segment around the rib is more reflective of those, if you remember, the intercostal nerves kind of sit, the nerve, artery, and vein kind of sits below each rib. It's intercostal nerve, artery, and vein. And so along that nerve is where we tend to see referral pattern if it is a costovertebral dysfunction or rib dysfunction. The other thing, and I'm gonna add that to this little section. So I will post this updated set of notes, so you guys will have access to that as well. Another thing that is indicative or may clue you in that's more of a rib dysfunction is you're going to have some sort of pathology associated with breathing. So because of the ribs mechanics as we breathe and movement as we breathe, because the costovertebral joint needs to attain full motion to have a normal inspiration and expiration, that can be an irritating or a symptom provocator if somebody has a costovertebral issue. So remembering that as we breathe in, your sternum moves in a pump handle motion, so kind of anterior and up, and then your ribs move in more of a bucket handle motion, so out to the sides and up to expand and let air enter the rib cage. That rotational movement of the rib of the costovertebral joint can be irritating if that's where the pain is coming from. Some of your objective tests that you might want to look for. So with facet, don't forget about your quadrant tests. So your combinations of extension and side bend combined, usually with overpressure is how it's described. So those would be your posterior quadrants, extension and side bend to the right, extension and side bend to the left, and your flexion quadrants. Usually your extension quadrants are going to be more indicative of facet dysfunction versus your flexion quadrants stereotypically are going to be more indicative of a disc-related pathology, especially in the lumbar spine, but still in the cervical and thoracic spine, you want to look at your quadrant tests, and extension quadrants are still going to be more provocative at your facets because, again, they're closing down those facets if you remember your arthrokinematics. Let's see, what else? Objective testing. We talked about tenderness at the rib if it's a rib dysfunction. You could also have breathing dysfunction, so asymmetrical breathing or limited chest expansion. That might be one thing that you would measure. Another issue that we see in the thoracic spine, and it's kind of combined thoracic spine and upper extremity because it does correspond with radicular symptoms or neurovascular symptoms. So thoracic outlet syndrome is what I'm referring to, where the structures that pass through the thoracic outlet between the clavicle and the first rib are somehow compromised, either compressed by that first rib lacking mobility, or it could be a muscular tightness that's causing compression or decreasing the space that's allowed for those structures to move through. So specifically, we're thinking about brachial plexus for nerves for the upper extremity, and then also vasculature for the upper extremity. So brachial artery, subclavian artery, and then as it runs and turns into the brachial artery. So some findings that we could see in these individuals, they're going to report some sort of paresthesia in the hands, usually either numbness, tingling, loss of sensation, could be a clumsiness, lack of grip strength, lack of motor control. It could also be something that clues us in that it might be more of a vascular issue, so some sort of temperature dysfunction, cold hands, pallor, blue, color change in the extremities, but also cold sensitivity. And one thing that you're going to want to rule out if it is bilateral hands, even unilateral, is you're going to want to rule out some sort of pure vascular cause, such as Raynaud's syndrome, where you have vascular insufficiency to the hands, versus thoracic outlet, which is really pinpointing compromise at that outlet or at that exit for those neurovascular structures. The other thing you can find in an individual with thoracic outlet, and this isn't necessarily something that you're going to test for, but sometimes people have an extra rib called a cervical rib, and that can cause dysfunction or decreased space in that area to compress those structures. Listed a few thoracic outlet tests here, so Roos tests, Adson's, Wright's, and those are kind of working off of that notion to try to recreate the source of compression or symptoms. And those are things that you're going to want to be aware of. Scoliosis in the thoracic spine, not necessarily something we're going to treat, but something you might need to be aware of. And especially for board questions, they may ask you about terminology associated with scoliosis, which is a little bit tedious, but I put a little bit of some notes over here to the right, which are things that you are going to want to know, just associated impairments with that scoliosis. So we'll describe scoliosis based on the convexity, so based on the outgoing curve. So you could describe a right-sided thoracic scoliosis is going to be a right-sided curvature in that thoracic spine. With a right-sided scoliosis, what you're going to see for associated impairments are these things on the left side. So shortened left intercostal muscles, reduced left side mobility, reduced left side aeration. Again, something that you're going to want to know just as a pattern of dysfunction for your board exams. And then on the right side, you can describe, and you can kind of see this, right versus left. And again, I'm just talking about a right-sided scoliosis. You can reverse it if it were left. But you're going to see an associated right side rib hump and right rotated vertebrae. So you can kind of think through that. As you have a right convexity, that vertebrae is going to be turned towards the right. Okay. And you can have breathing dysfunction as well. Like we mentioned, it can be unilateral, but you could also just have a gross reduction in chest expansion. So those are the main things that you're going to see in the thoracic spine. Again, highlighting facet and rib dysfunction up top, because those are pretty common. Thoracic overall is a less likely area that you're going to treat in physical therapy. It's mostly going to be neck and low back pain, but you will get some thoracic patients, and so it's important that you know some of those diagnoses. So as we move into the low back, I kind of lumped SI joint in here, and not necessarily a specific SI joint diagnosis. So sometimes in the SI joint, we'll think about diagnosing as if we can really detect joint motion, so a hypo versus a hypermobile SI joint. And in fact, what we know based on the research is that we're not very good at detecting motion, so the SI joint does not translate that much, it does not rotate that much, and because so the amount of translation is just millimeters of motion, and the rotation is just a few degrees, we're not very good at actually detecting with our hands or with our palpation and joint play how much that joint is moving and whether it is actually hypo or hypermobile. So again, what I would guide you to try to frame your thinking based off of is how your patient's responding to the treatments that you are applying, and then also looking at the cumulative summary of your clinical exam and your clinical testing. So instead of just doing your sacral PA, counter nutation, mobilizations of the SI, even a unilateral PA at right versus left SI joint, and trying to detect motion and really base all of your treatments off of that. You really want to look at some of these other signs and symptoms to guide your treatments, and then start to come up with a hypothesis. If this person, you really think based on your exam, has an SI joint that isn't moving so well and your joint mobilizations improve symptoms, then maybe you're on the right track. Are they really not moving that well? Not sure, but your treatments can kind of follow along that pattern, and that might be a better way to think about it. Similarly, if you have an individual who is young, female, postpartum or peripartum, so around the time of pregnancy, And we know that that timing changes hormone profiles and will increase the amount of relaxin in the body. And because of that, ligaments become more lax, and specifically the SI joint has increased mobility, and that can sometimes cause pain and dysfunction at that area. And so this particular patient may respond to joint mobilizations at decreased grades to kind of modulate pain. They may also respond to a little bit of external stability as in treatment, and so an SI belt can sometimes help these particular patients. That might be a good choice of treatment, but you're really going to want to base it on, again, your comprehensive exam. Specific SI testing to differentiate between, is this an SI joint issue or is it more of a lumbar low back pain issue, are going to be the best research tests, or the tests that really stand up to the research, are going to be this cluster of pain provocation tests that Laslett has described. I think I have 4 in here. So it's either a cluster of 5 tests, or sometimes they will describe it as 6 tests, in which case they will use a thigh thrust on both the symptomatic side and the asymptomatic side as that 6th test. So if you see a 6 SI joint Laslett cluster, that's the reason for that. But I think the most research and the base test that they research is this 5 test cluster pain provocation at the SI joint. And what this consists of is a compression test, so where you're trying to compress at both sides of the pelvis, a gapping test where you're trying to gap, and if you kind of think of this test in supine, pushing against both ASIS to gap or create a shearing force, and then a sacral PA, just a straight PA. Gainsland's test, which is going to look very similar to a modified Thomas test for assessing hip flexor mobility or hip flexor length with overpressure. So again, you're trying to create a rotational force to provoke that SI joint pain, and then a thigh thrust where you're creating more of a AP directed force at the thigh and at the femur, and using that to create or try to recreate patient symptoms. So if multiple out of those tests are positive and you are provoking the patient's pain, then you can be more and more likely that this is an SI joint issue versus a lumbar spine or a low back pain issue. SI joint pain versus low back pain. SI joint pain can have radicular symptoms or referral. Typically, if SI joint refers down the leg, it doesn't go below the knee. Usually it's very localized pain though, and usually people will point and say, where is your pain? And they will take one finger and they will point to the PSIS region. And so that pointing to that specific area or pointing to the PSIS is sometimes referred to, called Fortin sign, is just pointing to that area of pain. That will indicate SI joint. Sometimes it's described as the quarter sign, where again, somebody will take their thumb and finger and they will place that quarter size circle on that same region to describe their pain. So where's your pain? Oh, it's over my PSIS. They won't say that, but they will use this area to kind of place over where their pain is, and that's indicative of an SI joint pain. Versus lumbar is a little bit more diffuse, a little bit more widespread, usually sometimes with facet or maybe a pulled muscle. Maybe initially it will be very localized, but usually it will spread, it will be more broad. It won't be as low as the PSIS, it will be more in the lumbar spine. And then your lumbar CPAs and UPAs can help differentiate. The lumbar muscle palpation can help differentiate whether it is a lumbar origin or an SI joint origin. There are additional tests for the SI joint that are not on this list because they're not pain-provoking tests. They are more looking at alignment or stability at the SI joint. And those tests, though they may be described, though you may be tested on them, they are not necessarily research supported in our clinical practice at this point. So those are tests like the Stork test. So palpating SI joint movement while somebody's standing on one leg, the Gillette test, or the March test, which is palpating the opposite SI joint or the leg that's moving into a march. Their leg length discrepancy tests, short to long sit tests, forward bending tests. So those tests are SI joint tests. I'm not saying they're not, but they're not as well proven to indicate true SI joint dysfunction. Okay, so as we move on, lumbar. This is kind of analogous to in the cervical spine, we had treatment-based classes. Lumbar spine, these are our treatment-based classes, and these were the original, this was the original area, I believe, where these classifications were described. So for treatment-based classifications in the lumbar spine, my little mnemonic is individuals will either move too much, move too little, it will move in the wrong direction. Or is it that simple? You're pulling my leg, traction classification. So if they move too much, our treatment is going to be some sort of stability or motor control treatment. If they move too little, our treatment is going to be some sort of manual based mobilization or manipulation at the lumbar spine. If they're moving in the wrong direction, we're thinking this is more of a directional preference patient. So maybe they are irritated when they move into a flexion plane or forward bending plane. We're going to have them do repeated extension. This is going to be something that looks familiar within a McKenzie-based treatment type system or mechanical diagnosis and treatment, an MDT-based theory of treatment. Those are going to be your directional preference or special exercise patients. And then our last category of patients are going to be our traction patients. This is going to be the patient who has some sort of radicular symptom, has some sort of nerve root symptom, but cannot self-centralize or cannot get those symptoms to move out of the lower extremity and back towards the back. So they don't respond to directional preference exercises, or they may not be able to self-centralize for some other reason. This individual, we think there likely is compression at that nerve root. We're getting some sort of radiculopathy. So similar to within our cervical radiculopathy patient, we're going to want to decompress or take some pressure off that nerve root that's causing radicular symptoms. And so traction is going to be our treatment of choice, a trial of traction. If traction doesn't help this patient respond, then we'll probably pull from the different categories based on the impairments that we find. Maybe that individual does have some hypomobility. Okay, we're going to do some manual therapies. Maybe that patient does have some weakness of deep core muscles, and maybe we're going to do some transverse abdominis specific exercises or core exercises. Those are going to be our choices. If the individual doesn't respond to traction, traction is a little bit more of this catch-all category. It's not as well described. So those are the different categories. And then these are the findings that you may expect in each category. So I'm going to let you kind of go through these. These are pretty standard based on the literature. They're very well described in the original research studies. And as you can see on the left, I have citations for the treatment-based classification, and then it has been updated, constantly being updated based on the research and based on its ability to predict patients' response to these specific treatments. And so some of those findings are either pulled out or plugged back in, the factors that define these different treatment-based classes. But the standard things that are going to help you categorize into these different classes are for your patient who may need some movement coordination training, tend to be young, they tend to have a positive Gower sign, they tend to have positive instability tests, so prone instability tests, more flexible, and they need more stability or more muscle control. So weakness usually of the deep core muscles, could be weakness of the hip muscles, and just inability to turn those muscles on or know how to activate those muscles for these functional movement patterns, a squat, a forward bend, even as simple as it could be like a bed mobility, so rolling left or right or rolling from back to side lie. They could have dysfunction there. Prompting them to activate some of these deep core muscles could reduce symptoms. So that might be one thing that you look at within your clinical exam. Within our manipulation classification, these are going to be the individuals who are hypomobile. They're going to be hypomobile at a specific lumbar segment. And usually, again, like neck pain is going to be an acute onset Not going to have radicular symptoms. It's just going to be that hypermobility of the joint, of the facet joint. So this would be an individual who's appropriate for manipulation. If they don't meet all of the criteria, you might trial mobilization with them, or if they have some yellow flags for manipulation, they're not appropriate for that, mobilization could be a good treatment. Our directional preference patients are going to have, again, radicular symptoms. They're going to centralize with repeated motions, either repeated flexion or repeated extension. And then our traction, as we talked about, is going to be our patient who can't self-centralize, but they do have radicular symptoms. So traction may be a good alternative. And that could be either manual traction or more commonly moving into some sort of mechanical traction prescription. Okay, last few I have on here are going to be more pathoanatomical related. I think I'm running out of time, so this is good. So we got to this, so you have reference to it, but not necessarily in order to talk about it in depth, but we did talk about it in the other lumbar segments where a stenosis or facet issue, compromise of that nerve root exit, intervertebral foramen, is going to be more typically provoked in extension. So extension is going to be worse than flexion because you're closing down that opening. A disc sort of issue is stereotypically worse in flexion and relieved in extension. The other thing that you're going to want to note is with these stenosis patients, ruling out vascular claudication, and that you can do by just testing the positions. So if somebody has a lot of symptoms in walking, you're going to want to make certain that the position is more provoking their symptoms, and that would be a spinal stenosis patient versus the aerobic activity or the vascular demand provoking their symptoms, which would be more of a vascular claudication patient. So you're going to use what's called the bicycle test to differentiate. So if somebody's biking, they're in flexion, that should relieve somebody's symptoms if they have a stenotic underlying cause. If biking does not relieve their symptoms, then we think it's more of a vascular claudication, in which case the aerobic effort, increased blood supply, oxygen demand in the muscles is what's causing the symptoms versus a neural component.